My name's Jemma Barton. I'm Head of Quality Improvement and Clinical Effectiveness for NCIC.
And Ruth O'Dowd, I'm a consultant anaesthetist and Associate Medical Director for Patient Safety Quality Improvement and also Patient Safety Specialist at NCIC. So yeah, sorry, too many titles, lots of hats.
Okay, I'll share the slides and Ruth's going to start first. Okay.
Cool. So yeah, welcome everybody, and thanks very much to Click for inviting us to present at this session. So what we were going to talk about today, because it absolutely links to quality improvement, as you will see as we go through, is the patient safety incident response framework. I don't know, I recognise quite a lot of people on the call. I know there are quite a lot of people here from NCIC, but equally this is relevant absolutely completely across the region, and we'll absolutely try and we'll link it across to the application to all organisations, because I absolutely know this call is not about NCIC. So just to sort of flag that up, that although I can see a lot of the people on the call are from Cumbria, that is not the purpose of this. So if we move to the next slide, it's just a brief aims of the session. So just wanted to talk a little bit about the concepts and intentions of PSIRF and patient safety incident response framework. I am going to use the acronym PSIRF because that is the worst mouthful of words ever. To share the new terminology that comes with PSIRF and to acknowledge that it is all P's, S's and I's, and that makes it quite confusing, but we could do a quiz. To start some conversations about PSIRF, what it means and how it might work in all different organisations, but also across the ICB, because it is an ICB requirement as well, and recognising that implementing PSIRF is absolutely not a single action. It's going to be a journey. It's a change in the way that we look at patient safety and patient safety incidents, and to understand how PSIRF is absolutely going to support a focus on improvement projects and improvement in patient safety. Just as a quick straw poll, because I'm kind of conscious, can people, I don't know how best to do a straw poll, but I'm just curious to know how many people that on the call already know about PSIRF. How many people this is completely new to, perhaps? I don't know how best to do that on Teams, whether it's through the chat box, if people can just say, do they know anything about PSIRF or nothing about PSIRF? Sorry, I don't know, or whether we do it by hands up, but that is so new to some people anyway. Okay. Okay. So what I'm seeing is know a bit or new. So hopefully I'm gonna start from the assumption that most people don't know much about it. Does everyone likewise, does everyone on the call know about the old serious incident framework? I presume everyone is familiar with the concept of serious incidents in terms of patient safety. Would that be a reasonable assumption? Great. Okay, fantastic. So hopefully, please do raise your hand, ask questions if you've got anything in between, and then we'll hopefully have some chat about it at the end of the presentation. So just to kick off, if we have the next slide, please, Jemma. So patient safety. So what is patient safety? Patient safety is defined by WHO as prevention of errors and adverse incidents to patients associated with healthcare. I have a slight issue with this, as others who've heard me speak will know, in that I would suggest that it is impossible to completely prevent errors and adverse effects associated with healthcare, because healthcare is inherently risky. So for me, it's about minimizing the numbers of errors and adverse events. Having said that, the definition up is an internationally agreed definition, so I'm not about to be the one to change it. But I think recognizing that what we're talking about is minimizing is underlined by the statistic that every 10th patient in Europe, which might be considered to have advanced healthcare, experiences preventable harm or an adverse event whilst in hospital. So that's, 1 in 10. That's a lot of adverse incidents, which I think we would all recognise. So up until now, we've had the serious incident framework, and it's been very piecemeal the way that we've addressed patient safety generally across the NHS. And in 2019, partly as a recognition of this, we had the first national patient safety strategy. So the NHS patient safety strategy, the first of the P's and S's, was introduced in 2019. And that described how nationally patient safety would be approached, and it underpins it with intelligence, so gathering information from incidents and complaints and litigation and indeed importantly patient feedback. So gathering the intelligence and using that to make improvements involving patients and staff. So that's some of your eyes. And that was what the patient safety strategy set out to do. And as part of the NHS patient safety strategy, every trust was mandated to identify at least one patient safety specialist within the trust. So all of your organisations should have and will have, in fact, a named patient safety specialist. And I'm one of the named patient safety specialists for NCIC, and we link together. There's a network of patient safety specialists both across the region and the ICB and nationally who join together and share information about patient safety, so that there's a more joined up approach, and the approach is more joined up than it was previously. At NCIC, we in North Cumbria, we were probably a little bit ahead of the game on some of it, in that we've been using a human factors and systems based approach to learning from safety incidents since 2018-19. And that was about moving away from an approach that tended to focus on staff and individuals who didn't follow the process, didn't follow the guideline, who gave the wrong drug, with the emphasis on the fact that if you retrain that person, or you told them not to do it, or you told them to follow the guideline, that would make care safer. And I think we probably all recognise that that is not effective learning. So we moved, as I say, in 2018 or 19 to use the systems-based initiative for patient safety, SEEPS, for all of our SI investigations. And the concept of that is to look at the system behind any patient safety incident or error, and looking at the impact of the organisation, both externally, so perhaps COVID or just general system pressures, within the organisation itself in terms of flow and pressures, the internal environment, so what the environment looks like where someone's working. Is the lighting good? How is it arranged? The tools and technology, does the computer system work? Was it broken at the time? How quick is it? Does our clever package of technology actually work fast enough to be able to do what we want it to do? So some of that's, I don't know to what extent you're aware of the concept of work as described versus work as done. So we can write a nice guideline that says this is exactly how we're going to do this process, and the person writing that guideline doesn't have to be anywhere near the place where the people are working, the staff are working, that have to carry out that guideline. And then you end up with a complete disconnect, where you can have a guideline or a policy that describes a way of doing something that frankly nobody in terms of members of staff ever do it that way. And and then if you talk to staff and you say, well, why did you do it wrong? It's like, well, because I did it the way I always do it. Oh, but that's not the policy. Well, the truth is you need to fix the policy, not the staff, or you need to consider how to make things work so that the staff can do that. So this is the concept of SEEPs and systems engineering. It's about learning from, and this is used in other industries. So this is absolutely coming from human factors and systems engineering that's used in places like the airline industry, and it's also used in other industries with high reliability. And often there are multiple contributing factors, and that's one of the things where it kind of moved away from root cause analysis. Is it's very rarely one thing, because healthcare is incredibly complex and there are nearly always multiple things playing together. This is a really rapid, this is a bit about systems approach. Clearly, to understand more about it, there are courses in learning, and in fact that they're quite easy to access now, courses in learning about SEEPs and systems based. In fact, HSIB are about to enroll people on some courses for that. So if we go to the next slide, so this comes to why would we want to change from the current SI framework to PSIRF. We did a workshop back in February talking to staff in North Cumbria about this, and one of the things we did was looked at what the problems people saw within the SI framework and what they'd like to see. And it was from in fact more than one workshop, and actually workshops elsewhere. There's a general consensus that the SI framework, which was from 2015, is time consuming. It's largely driven by a need to close SIs, to complete a report, submit a report, and close the action plan at the end of it. And closure is seen as an endpoint. So you've completed the action plan, SI closed, tick, put it away. There has been a tendency not to have very good patient and family engagement in the process, and staff often comment that they haven't been involved in the investigations, and that they're not always aware of the outputs. The family are obviously involved because it's mandatory in terms of duty of candor, sorry, the family or patient, but the actual involvement in framing the investigation and understanding the output of it is not always there. Action plans tend to get lost from SIs. That's a consensus, and most people feel that the SI framework tended to lead to blame of individuals. And some of that is about the need to close action plans. It's much easier to write an action that says we're going to make someone do some more mandatory training, we're going to share this incident at a meeting, because you can give the meeting agenda, tick, done that, but it doesn't actually mean anyone's learnt, and it doesn't mean that patients are safer. And the other thing that is commented on is that we keep learning the same thing over and over again. So we relearn, which kind of probably suggests we didn't learn at all. I think we would all agree. So what would they like to see in PSIRF? These are obviously things turned over. A focus on patients and families, much more support to staff involved, recognizing that second victim, recognizing that whenever there's an incident, very few, a tiny minority of staff would actually want to be doing harm. And that's an aberrant group, and they're absolutely not the norm. The vast majority of staff come to work to do a good job. And I think we will all know, if we've been involved in incidents, or when we have colleagues involved in incidents, how upsetting that can be, and how much people go away and reflect, and they need support and they need understanding, and we need to prevent psychological harm to our staff when they're involved in incidents. And then absolutely focusing on improvement, not just doing investigations. That's one of the things that came through really clearly on the feedback. Better reports that can actually be understood and mean more to staff and family, more effective sharing of the reports and the learning, so people actually know what's gone on with with incident investigations, and more effective improvements coming out. So that's the feedback. Unfortunately, that is reflected. If we go to the next slide, please. So why change? This is the from the PSIRF document, and I think you'll see that our feedback is much the same, that we're trying to investigate too many incidents with not enough resource, and they're repeated investigations, not finding the real causes, and not enough focus on common factors and implementing systematic change. So our feedback absolutely feeds into this, which is, I guess, is kind of good, because it means PSIRF, we're open to it. I think most people are open to it and see it as an opportunity to improve. We need to do better. Sorry, next slide, Gemma. So how do we achieve that learning? This is what underpins the way that PSIRF will be implemented. PSIRF talks about compassionate engagement and involvement of those affected by patient safety incidents. So by those involved is absolutely patients, their family, and our staff. And it's compassionate engagement. It is involving people and talking to them and learning from them, but doing it in a compassionate way that understands the impact of those incidents on all of those involved. An application of a range of systems-based approaches to learning from patient safety incidents. I'm really proud that Gemma and I, to be fair, have been involved from the start, but I'm really proud that we picked up on SEEPs and have been doing it in the trust for a few years. It's put us ahead of the game, and this is SEEPs is the described methodology for patient safety incident investigations within PSIRF. So it's absolutely about systems-based approaches, and that's at every level. So even if it's not a full SEEPs approach, it's understanding that system approach. So that's how we're going to be looking at safety incidents. And considered and proportionate responses. So we don't need to do an in-depth investigation of every incident, and we don't need to do a separate in-depth investigation of 10 different incidents that are essentially very similar. We can group those together and investigate them together and learn and do a single improvement plan. So that's and some incidents need a much smaller investigation. They might just need a debrief. They might need a huddle to look at what we're learning, whether we've got things already in place. Have we done the improvements we've already got improvement plans for? So a considered and proportionate response to patient safety incidents. And then supportive oversight focused on strengthening the response system functioning and improvement. That is a lot of words to say. Greater ownership by the organisation and those involved of the improvements coming out of safety incident investigations. And supportive oversight is about the fact that if we as an organisation, whichever organisation we work in, or the ICB, if it's a cross-organisational safety incident, if we agree, if the board agree to an improvement plan, then there's an expectation that they will support the implementation of that improvement plan, and the oversight of it is as a critical friend. So it's a kind of a move away from assurance and tick boxing to actually trying to talk about implementing and embedding improvement. So these are how PSIRF sees achieving effective learning and improvement. So next slide, please.
Do you want me to pick this up, Ruth?
Yep, and I shall hand over to Gemma from here.
Okay, great. I can't, because I'm sharing slides, I can't see anyone, so apologies for that. So in terms of...
Gemma, do you want me to share, or are you happy sharing?
No, it's fine.
Okay.
So in terms of the bits and pieces that Ruth's already discussed, this slide kind of depicts where we're trying to get to with PSIRF and the national kind of travel around this. So for those of you who've been involved in incidents, we know serious incident investigations, we know how long they take in terms of undertaking an in-depth investigation and the numbers of investigations that we've previously undertaken. And so there's been kind of a disproportion there around the number of investigations versus actually doing the focusing on improvement-based action plans and following those improvements through. So what PSIRF does, or it will attempt to do, is set that balance really. So there will be a balance between the number of investigations and an improvement focus. So really, as we said, really shifting that that focus around improvement. And what that leads to, hopefully, and it will do, is a release of capacity. So instead of lots of people spending lots of time undertaking lots of in-depth investigation, there will be a more proportionate response to patient safety incidents and events that will hopefully move to an increase capacity to support the improvement initiatives across the organisation. That being said, there will of course be incidents that will still require investigations. So there'll be those incidents that legally require investigations, like never events, and those incidents meeting each baby counts criteria, deaths, and some of the screening incidents. There will be the incidents that match the trust priorities, which is linked to the patient safety incident response plan, which I'll come on to in a moment, which is our the development of our local plan. And then there will be other incidents that would have previously been considered a serious incidents, but will be managed in a different way in terms of the investigation. I suppose what's really important in terms of this is throughout this, there is compassionate engagement of those involved. So as Ruth said, patients, families, and our staff. And these will all link to some sort of potentially some sort of investigation, depending on the incident itself, but all link back into improvement projects, so that once we've defined what our improvement priorities should be as an organisation, understanding how if we have another incident that's similar in the future, understanding whether that improvement project has made a difference, or if we need to try something else, and always having in mind that kind of iterative cycle of improvement and making small changes and understanding where they are, making improvements in practice. So in terms of how we will undertake other incidents that would not legally require investigations. As Ruth said, there is other forms that we can use, such as huddles. We can do stuff, things like use methodology like after action reviews. We can use thematic reviews, so we can pull together a number of similar incidents to understand what the key themes were. So, as I just mentioned, one of the key things that we need to do as an organisation is the development of a patient safety incident response plan. And this needs to be agreed by the ICB and be implemented by autumn 2023, so this year. And in terms of this plan, this is around understanding where we are as an organisation and where our improvement focus should be, and to be able to do that, and in order to do that, as stated here, we will use a local situational analysis and review of evidence. And what that basically means is we will use sources of information and intelligence that we have within our organisation to understand what our key improvement focus should be. And these sources of intelligence could come from incidents, complaints, mortality, litigation, risk, patient experience, staff surveys. And with NCIC, we have already got in place 10 quality improvement priorities, and they were developed from a review, particularly around serious incidents, but looking at other points of intelligence to understand where our focus should be. and they have been in place for around 18 months, 2 years now. So again, we've because we knew this change was coming, we have tried to kind of have kind of a positive movement towards the focus on improvement within NCIC. And as Ruth said, there is a lot of change in terms of oversight, roles and responsibilities, both for the organisation and at an ICB level. So there will be increased oversight at a board level in terms of understanding the key themes and any areas of improvement for serious incident, but more so around having oversight of quality improvement projects and supporting the resource required for those improvement projects to take place and be embedded. So what PSIRF aims to do is shift the focus to improvement. We know that blame restricts insight, so it's moving away from that blame culture to one around just culture. We know that collaboration is the key, particularly on thinking about a forum like today. So how do we collaborate within our own organisation, but how do we work together better across organisations? So that's not only about doing joint incident investigations, it's about how do we develop joint improvement plans that work across our organisations for better outcomes for our patients. Ensuring that we've got good psychological safety within our teams and within our organisations, and that's to ensure that staff feel safe to raise concerns, and that allows learning to occur. And that curiosity is powerful. We need to ask those questions to understand where the areas of improvement are. Okay, this slide is around thinking about oversight. And there's a couple of quotes on here from an independent investigation in East Kent. And it's about our regulators. So regulators of healthcare, for example, the CQC, and how they may need to shift in terms of some of their thinking and some of their investigation and inspection frameworks to ensure that staff do feel safe to raise concerns. And as it says here, there was a quote from one of the independent investigations here, and it said people don't always get rewarded by being honest. And it's a really important matter, because if the culture from regulators needs to be one around psychological safety, so that staff do feel confident to raise any concerns. Then moving on, I just thought it would be useful in terms of, as I mentioned before, around the development of our plan for PSIRF, to share with you our quality improvement priorities. So these priorities, as I say, were developed from a number of different information sources, and we've done work across all of these over the last 12 to 18 months. And I just thought I'd pick out a couple just to give you an update really on some of these. So, for example, the work that we've done around improving pathways for patients who lack capacity consent. So this is one that I'm involved in. It's a clinically led group that has clinicians from across a number of different areas within the organisation. And to start this piece of work, what we did was we wanted to try and understand where we were at that point. So some of that was around understanding at kind of our current state. So we conducted a number of different things, one of which was around an audit into consent form 4. and then we made some improvements in terms of some basic things around some changes to consent form 4, and we put that into the policy. We're doing training with the safeguarding team. They've done a significant amount of training around capacity across the organisation to try and embed some of that. But we know training only goes so far. So the safeguarding team are actually going out to individual wards and meeting with members of staff to support them with things like the application of dolls. We are doing work around the development of pathways of care for patients who may lack capacity to consent. Linked to this, we've just also pulled a number of different groups together. So we're now doing specific pieces of work around learning disability standards, the national learning disability standards, and the gaps that we know that we have around that. Particularly, we're looking at cancer services and our cancer pathways, and looking to make changes to enable people maybe with a learning disability to have longer appointments, or the first appointment of the day or the last appointment of the day, and working with patients, families, carers, to try and ensure that we have parity in terms of our services. The work that's been ongoing is, if we just pick out improve results, review and action. So this is one that myself and Ruth are involved in, and Ruth leads on this. Again, it's a clinically led group, has met every few weeks, and it's around our ICE results system. This improvement project came directly from a number of SIs. We knew we needed to make some improvements to the way in which our results are reviewed on our ICE system, and also how they are filed. We've done a number of pieces of scoping work around the processes and process mapped that, and now we're trying to take some recommendations back to the actual supplier of that IT system to make some improvements, and to understand whether those improvements to the system will kind of solve some of the issues that we currently have. Falls prevention, we have a trust-wide improvement plan in place for falls, and then there are individual service level falls prevention plans in place at a ward level. Liz Klein is heavily involved and leads on this, and it's seen some improvements in terms of the number of incidents that have resulted in moderate or above harm from falls. Okay. So I'll just come out of this presentation now so I can see you all. So in my group there was Hannah and Donna Luthwaite. So I don't think Donna's on now, but so Donna's view in terms of the improvement priorities were around the focus should remain on AKI, the work that she's leading on with others in terms of a priority. It was a useful conversation to understand where we are now and where we need to be. So the focus has been on education and really raising awareness around AKI. I suppose in thinking about a PDSA cycle, now she needs to move on to auditing to understand whether that education has improved anything in practice, and then looking at other ways to make improvements. So looking at putting fluid balance charts onto WebV. So it was a useful conversation. And then there was another discussion around escalation and documentation in our notes. This is linked to a sequin that the organisation has for this year as well. And also interestingly is linked to an audit that we've just done on 7-day standards. So the number of consultant reviews that patients have when they're in any of our wards. So it was quite useful to try and link that evidence up. It was a good discussion. And then when we talk about PSIRF in terms of communicating, It was about just trying to get out to as many different forums as possible, but understanding that some incidents will still require investigation, and how we will do that at kind of a serious incident investigation perspective, because there is still going to be a requirement for some of those to take place, and whether we think about having a dedicated role or having roles that are part clinical, part investigator. So that was the feedback from my group. Does anyone else want to give some feedback from the discussions that they had?
Yeah, it's John here. I was on the
Thanks,
meeting
John.
with Rachel and Kim, but who both had to leave. So I can either blame them or take all the credit for these, depending on the response. So firstly, there was some feedback around standardization across trust. And we were talking about formal induction in wards as well, so that, you know, the question was raised about, actually, is the potential increase in incidents happening because staff are being moved from ward to ward at short notice, but don't necessarily have the same practices in place. There was a long discussion around psychological safety within the trust, and actually related to that with around the staff survey, and around, you know, empowering, engaging with the teams as well. But, you know, if we haven't got that psychological safety in the trust, we're not going to have open and honest discussions. And that sort of led on to the second question around how best to communicate. One of the things that was identified was that not every team has a team meeting. They might have huddles, but they don't necessarily have a team meeting. Or if they have team meetings, they don't necessarily happen on a regular basis. They might get cancelled due to operational pressures. And really, that it's one thing having been informed around, say, PSIRF through like the trust weekly brief, but it's a different thing actually having a discussion around that as a team. And, you know, we were sort of talking about the fact that on a wider issue around, if you had regular team meetings, actually, if you could have certain discussions, we wanted to have a consistent approach to those team meetings as well. So, you know, if you wanted to promote PSIRF, that would be perhaps a discussion point for that team meeting that particular week.
Yeah, great, thank you. Okay, anyone else want to give any feedback?
I'm noticing you're on call. Were you in one of the rooms with?
Sorry, I couldn't. I've got a sick child, so she's just left.
Oh, bless
so
you.
I couldn't log on. And she's quite chatty as well. She likes to look at people and chat, so I just had to come out for it.
Oh, that's okay. Sorry, I didn't mean to pick on you and identify.
No, it's fine. It's
I
fine.
apologise.
But she's gone now, so I'm okay.
Oh, good. Okay. Tammy, Mel, do you want to feedback what we discussed?
Yeah, sure. So sadly, we both, myself and Melanie, are from the PMO, so we are not clinical with this, and we've come on here to learn. So we sadly weren't that much help with the questions. What we did suggest is to get the message out there. What worked well for us is to take on smaller groups when you're dealing with the clinicians. Team brief is great, but you have no way of knowing who you've reached and who's taken it in. Communication going out to people en masse, again, you don't know who's read it and who's taken that in. This sort of thing needs to be communicated face to face, and the way that we're getting around currently, because it's very difficult to get engagement from the clinician just because of their workload, is take it down to a very smaller group and do more smaller sessions rather than large sessions, and you've got more chance of getting engagement that way. We also discussed how we put this through, and Ruth made a very good point that it should be bottom up, because that's the people that's dealing with this on the ground, which would be absolutely fantastic to get that sort of engagement. But we often find it's who asked the question. So when we're asking as a PMO, we don't tend to get that much response, and we have to lean on the exec to get their back in, so people are aware that the exec are behind it to get the engagement that way.
Okay, thank you.
So we had it was quite an interesting discussion about that. And I think the other interesting discussion, and maybe I need to pick up with John, was about how the PMO do and don't feed in, because we had a discussion about what the patient safety improvement priorities might be and how we get that information. And we had a discussion about whether the PMO does or does not have a role within that, and the extent to which it's a go and ask versus a reactive PMO to what they're asked to do, versus where there could be a proactive approach of this is what we've got to offer, which I accept is slightly philosophical, but we had a bit of a conversation about it. The other challenge, and I will put it myself because I said I would be quite comfortable doing, and I think John's already aware, was the challenge that I think as part of PSIRF, but also as part of patient safety, my challenge would be that any project that the PMO are leading on should have unintended consequences to patient safety as one of its outcome measures, which I'm told is not the case at the moment. And I would suggest that in this organisation, but also in other organisations, so absolutely, I don't think this is just about North Cumbria, that unintended consequences on patient safety should 100% be an outcome measure in some way. And I think I think that would be, and we, as I say, we did talk about top down versus bottom up and the challenges of that with the staff engagement and how you perpetuate it by top down, but it's difficult to flip it over and get the bottom up engagement. Sorry, John, you wanted to say something?
No, I was just going to say, I know we're currently revising our team SOP, and one of the things I've been considering about putting in is around the QIA, so that every project as part of that as a QIA, so that it identifies if there is any like you said, unintended impact on patient safety, or a number of different areas as well. It's something that we do as part of when we're doing cost improvement plans with a PID document, but it's not necessarily something that we're doing from a project point of view, because we tend to be brought in, and it's something we're trying to address at the moment, is we tend to be brought in when the project's already started, and then they suddenly realise they need project support, rather than being brought in at the very start when they're doing the planning. But I appreciate we've moved from PSIRF onto PMO, but we can happy to have a discussion offline, Ruth, about that.
Yeah, no, that would be great. No, well, I suppose it's just recognising that PMO may well be part of implementing PSIRF, and I guess that was my question about the proactive reactive thing and the interaction, and that was part of the discussion, was the interaction between PMO project management versus quality improvement, which I think again is part of the philosophy of PSIRF and how that works. And again, I suspect, and it will be, we haven't got anyone from out with the organisation on the call now, but it will be interesting to understand how that is playing out in other organisations, because I think it will be. I think that tension is part of it. It is part of PSIRF.
What you might not be aware of is that we're supporting the staff survey, the implementation of the staff survey results, and there's we've put that onto a project plan, and within that project plan there are a number of actions relating to PSIRF.
So I'm completely unaware of that, which is an interesting disconnect.
So we're at the stage now where we've identified what the actions are, and then we'll be contacting each one of the relevant leads.
So
to
is
say,
the overall plan shared anywhere?
No, because at this stage we've not completed the plan. We're just
Right.
trying to identify the actions and identify the relevant leads. But having, worked with Stephen Park on the draft of this, I know that there are some actions relating to PSIRF in there, and we have put your name against it.
And presumably, this is going off this. I probably need to talk you out with, because I'm assuming that the actions will be agreed with the leads in developing,
Yes.
and that's the
Yes.
bottom up part, isn't it?
Yes.
It's the not
Yeah.
dictating, it's the involving.
Yeah.
And I think bringing that back to the way it works with PSIRF is the part of the philosophy of PSIRF is 100% compassionate engagement. And I think compassionate engagement and involvement of staff and patients as part of all of our improvement design to improve patient safety absolutely underpins PSIRF. And I think that if I was going to give a message to everybody across organizations about what PSIRF is about, that is what it's about. And actually, for me, it's some of it is about a changing philosophy to the way we work within the NHS. And I would, I mean, I am a bit of a zealot for it, and I know that, but and I make no apology for it, but I think we need to change the way we work more broadly, and PSIRF is one part of that. But I think if we can use it to change the narrative and change the way we're working, we will go a long way. John?
I was just going to say, there's a book called Black Box Thinking by Matthew Said, which you're probably aware of, but for those of you who aren't, it's a fantastic book that talks around the way that we deal with incidents, and the fact that if you're in the aviation industry, if anything goes wrong, all the information is openly shared, and they all work to try and make improvements, whereas I think it's acknowledged within that healthcare is perhaps not that same philosophy.
Yeah, and absolutely as part of that and Matthew Said's work, I think really importantly, there's also the question of bringing in that diverse view, so that if your team is made up of a group of people who all have the same thinking, and that would apply to any team, that applies to the patient safety team as much as to the PMO team or a clinical team. If your team is a group of similar minded people, then you risk not seeing the bigger picture. And that certainly Matthew Said's talked about that in terms of Twin Towers, and the expectation was that they were not that the people looking at safety, they did not bring in a diverse enough range of views in considering where the risks came from. And I'm not sure if that's in Black Box or his other book, I have to say, but that inviting in diverse views, I think, is really, really important. So I think that's a really good point, John. Has anyone else got any? Sorry, Gemma,
no, it's fine.
Interrupting, but has anyone else got anything else that they want to say or ask about PSIRF? Indeed, because I know it was a bit of a fly through, and I have a feeling that those of you on the call, probably it was all a bit new. We have got an implementation board, and I think certainly Gemma and I and Liz Klein's very heavily involved in it. Any of us be really happy to talk to anyone, and Hannah I know knows loads about it. Really happy to talk to anyone about it, and come and talk to teams. I absolutely agree with what Tammy and Melanie were saying about talking to small groups, and getting out to team meetings, and that's the way we will be doing it. And I think it's a really important way of doing it. I think relationships and conversations is the way forward with this.
What's the feedback so far, Ruth, on this? Are people aware of it? Are they supportive of it? Because it is quite a change, looking from the outside in. It's quite a change in the philosophy of how incidents are.
I think the feedback we've had from the, I mean, we've only done one sort of big workshop, and I've talked about it at a lot of smaller educational meetings that I've been doing. I think generally people can see why it's good. They think it's a good idea. It to some extent it's building on what we're already doing in the trust. I think there is a lot of concern about how our patients and families will understand the fact that not every incident will get as much investigation as it did previously, and that's been a concern nationally about how that's communicated. And I think a lot of that's about good conversations with patients, but that is a concern.
Is that are PALs actively involved in this then?
Yes.
Yeah.
Yeah, PALs are involved in it, and they need to be. And indeed, we now have a patient safety partner in the trust. So one of the other things that was mandated was appointment of a patient safety partner, which is a volunteer role, so that we will have patient representation at our safety and governance meetings. And we now have a patient safety partner who was appointed through PALs. So we now have one. We'll be we're hoping to recruit some more. So that's absolutely part of it, and I think it's a really good point, John. It's really key.
So I think in terms of as Ruth said about having conversations with patients and families, what we know is that when something goes wrong, what patients want is for it not to happen again. So non-dependent on the type of investigation you do, as long as you're having ongoing conversations with patients and families and you're able to demonstrate, and really what PSIRF is trying to get us towards is involving patients and families in those improvements as well, if that's what if they want to be. And I think that is quite a big shift, but that's where we need to get to.
I think it's a long time ago now, but you know, we as a family put a complaint in. We're talking about 22 years ago, but but there was a couple of things there to sort of, I suppose, learnings. One was that there was a consistent contact point.
Mm-hmm. Yeah, absolutely.
And then secondly, that it was the response was very timely. So you know, I think because we get bogged down in lots of different things, if we're not careful, you know, it bounces around between people, or it takes a long time to respond. And you know, I think that's from a patient point of view, that's the key frustrations, isn't it? They want to feel like they're being listened to, and certainly from our point of view, it was all about making sure it didn't happen to another family.
Mm-hmm. And it's very interesting at the Patient Safety Congress last year. There was a really powerful presentation from an ED consultant and a relative whose daughter had committed suicide after a series of things, and the case was to go to the coroners. And one of the big things of the feedback was that when legal services got involved, and it became a don't talk to the family because you can get and it became legalistic. And one of the things that the clinician reflected on was actually when they were at the inquest, they'd not spoken to the family as well as they should have done, but when they were at the inquest, she actually bumped into the patient's relative, and her clinical human head took over, and she talked to this relative, and the two of them came and presented together, and it was absolutely what we needed was that conversation, and what we needed was for the process, the rules not to get in the way. What we needed was a conversation that was, we know things didn't go as well as we would have liked, we're learning. And it was really powerful hearing both these people talk, because they were both damaged by that. I'm probably not recounting it quite right, but by that inability to communicate, with perhaps a false barrier put in that said you shouldn't do it, when actually exactly what you say, John, that timely, if someone had just gone in and talked early, that's what the family wanted. And actually, ultimately, that's what the clinician that's what their gut told them to do. And I think not losing that and actually bringing that up to the fore and being brave to have those conversations, because sometimes it's really hard as a clinician when things haven't gone well. It's really hard to especially if it's about reaching out. It's easier almost in the moment than it is subsequently, but the more we do it and the better you do it, and we can all do it as clinicians, we all know how to.
And ideally face to face as well, because
absolutely,
that makes a huge difference.
100%. Keep off the letters and talk. Tammy?
No, sorry, I was going for the clap rather than the hand there. When you said face to face. Apologies. I'll try and bring it down.
Okay, Ashley, shall we wrap up there, because you might have a few?
No, that's great. Thank you so much, Gemma and Ruth. And actually, I was just sat here thinking it might be really good to bring this into our system improvement subgroup as well, to kind of carry on these conversations, Gemma, because as you said, you know, collaborating on this across organisations will be great, and that might be a really good forum in which to be able to do that. So yes, if anybody's interested in joining that, as I said earlier on, please just get in touch.
I think
I definitely am, Ashley. I think
you
I might
are,
already
Gemma.
I'm not sure. I think I might be on the list already, but if I'm not, Ashley, then definitely.
I'll add you, Ruth. That's fine. Yeah, no problem. Brilliant.
And just to say, like, anyway, if anyone's got feedback on this session, I don't know whether you get feedback, Ashley, on it. It'd be really helpful to have feedback on how it goes. I personally, I find Teams really hard, but I know the value of it, but I do find it hard. But feedback would be really helpful, and suggestions for how we can improve would be really useful.
Brilliant.
And equally, conversations. If anyone wants to call and talk about it, please do get in touch.
Brilliant. No, that's great. Thank you so much.